Well, thank you, Megan, for joining us. She is joining us today from Michigan. She will tell us a little bit more about her practice and what she does, but I met her through Instagram and saw what she talks about, and it was talking about supporting patients with MASLD. So I asked her to talk a little bit about how she supports patients, how she incorporates nutrition therapy using the guidelines. So we'll have Megan, you can give your presentation, and as questions come up, you can pop them in the chat.
Okay, sounds good. Thanks, Crystal. So, yeah, my name is Megan. I have been a dietitian for the past 5 years, and I have a practice in Metro Detroit. So, if you look at your palm, it's like on the very bottom part of the heel of your thumb. And I was really excited when Crystal asked me to present to you guys. MASLD is something that I see on a very frequent basis. So, to give you a little bit more just info about me, primarily what I do on a day to day basis is medical nutrition therapy. I also do culinary cooking classes, I do corporate wellness services. So, I have my hands in a little bit of everything, but mostly MNT. So with MASLD, you guys should have, read a lot about it so far, but just as a brief recap, um, it's when more than 5% of your liver cells, your hepatocytes, show accumulation of triglycerides. So, this is also going to be independent of excess alcohol consumption, other etiologies that would explain the fat accumulation. Until recently, it's been called non-alcoholic fatty liver disease. We frequently also just shorten it to fatty liver. That's probably, as you guys go on to do your clinical training, it's probably how you're going to still hear it referred to. It just takes time for new names to catch on. So we apply medical nutrition therapy through the systematic and nonlinear framework of the nutrition care process. So let me ask, is the nutrition care process something you guys are applying or, learning about in your coursework right now?
Yes. So yeah, all of these students have done their
Yes.
diet internship. So
Oh, they have. Okay. Okay. Awesome. So, yeah, today we're really just going to focus on the assessment, diagnosis, and intervention part of it. So, when I get a new patient with MASLD, the big question in my mind for the assessment is, what's kind of going on medically, lifestyle right now, what's happened in the past, and kind of what answers will bridge the gap over a person's history that offer an explanation on the current diagnosis and that will inform treatment. So, going into the assessment, one of the first things I'm going to review to give myself some context are the labs. So, we will look at the liver function labs, but personally, I'm more interested in the metabolic labs and the lipids. The idea with AST, ALT, enzymes you guys should be familiar with, primarily found in the liver, is that when they're elevated, it's indicating some degree of liver injury present, leading to leakage into the bloodstream. But in some cases, in people with MASLD, they're not as sensitive. Some patients can have normal values despite having MASLD confirmed with CT or MRI. So they're definitely not an absolute marker for the detection of disease. And the reason why I'm mostly interested in the metabolic and lipid labs, we have a lot of evidence suggesting that there's a bidirectional relationship between the liver and other endocrine organs. So your pancreas, your skeletal muscle tissue, and the concepts of the personal fat threshold and twin cycle hypothesis are hopefully things you've read about at this point, even if you haven't heard those, terms, those names specifically, but I do have articles linked to those at the end of this presentation on the resource page that you'll be able to click on, read more about. But essentially, we have a self-reinforcing cycle of deranged lipid metabolism and insulin resistance that's driven by a chronic energy surplus, someone eating more energy than what they need just for kind of like maintenance of their body composition. And that is going to exceed capacity to store it adequately in subcutaneous tissue, where then it's getting stored as visceral tissue. And this can be accompanied by insulin resistance, particularly of skeletal muscle tissue, again, either due to energy surplus causing intracellular fat storage in cells, or a physical inactivity, some combination. So really, with medical nutrition therapy, the primary things that we can address are correcting energy surplus, changing body composition, and improving the quality of the skeletal muscle tissues and their insulin sensitivity. So, in addition to understanding the labs, getting the medical history, that are helping to us kind of paint this picture in our assessment and start to think about what interventions we might apply, we're also, going to collect anthropometrics. But the first thing I always, want to say is it's important that we approach collecting anthropometrics with a lot of sensitivity. We always ask for consent to take measurements. I always ask even to take scale weight consent for that. Patients, when you see patients with MASLD, a lot of them will be in bigger bodies, and it's well documented, well known that people in bigger bodies experience a lot of harm in medicine and poorer care due to weight bias. So we always want to try to practice from a weight inclusive space. We're not saying body composition doesn't matter, but it's not the only thing that matters in MASLD. It doesn't have to take the front seat if it poses a major mental health risk, for example, if someone has a history of disordered eating, eating disorders, or if the patient just simply doesn't want to pursue it. I've had a lot of patients make great strides in treatment without ever collecting a single scale weight. So definitely not necessary on my end. We also, frequently have patients in smaller bodies that present with MASLD. So the graph to the right is from a review. It's something like I like to present because it shows us that, on a population level, BMI is pretty representative of, or pretty predictive of, adiposity. And although, insulin sensitivity does tend to go down with higher BMI, plenty of lower BMIs also experience decreased insulin sensitivity as well. So if a patient is open to it, waist circumference is a pretty good predictor of visceral fat storage. Sometimes I also take mid-upper arm and calf circumference. Those are good markers of musculature. And these can also be helpful metrics just to track over time. The second step of let me back up. So last part of the assessment is personal history. So other things I'm collecting would be, dietary history, whether that's a 24-hour recall. Some patients like to keep a food journal before they come in, really adequately reviewing their personal medical history, family medical history. I want to know what kind of physical activity they're engaging in, whether it's, do you work a desk job versus, a job that involves more movement and also exercise. I want to know any limitations to physical activity. I always triple check their supplement and medication usage. It is super common that patients will report no medication usage, and then halfway through the appointment, they, tell me they're on something. So always triple check. I want to also kind of gauge their knowledge about their current health status. I would say 9 times out of 10, when a patient receives a MASLD diagnosis, or honestly, a lot of different diagnoses with any health conditions from their physician, the level of education that they're provided about, exactly what it is pretty insufficient. I also want to know about what food do they have access to, their preparation ability for food, and then any subjective data that, they might volunteer themselves as well. So the second step of the nutrition care process is making your nutrition diagnosis through the PES statement. So it sounds like if you guys have done, your internships, this is something that you should be pretty familiar with, making these statements. So these are pretty common nutrition diagnoses I typically use for patients with MASLD. So keep in mind, just when you're deciding on one, they're not the medical diagnosis. It's just a nutrition-related problem that can be addressed with your intervention. And you also want to prioritize your diagnosis. So you shouldn't really be, writing 5 different ones. Really try to capture a high-level overview of the issues, and usually 1 to 3. But, the most common ones I would say are altered nutrition-related lab values, excessive energy intake, physical inactivity, and then knowledge deficit. I threw a couple couple other ones in there as well that can be used, but I typically use those on a less frequent basis. And we have the third part of the nutrition care process, which is intervention. So we've identified the problem, reasons behind it. So now we start to think of how we address it. So this is usually really the meat of nutrition counseling. A lot of your first appointment will be kind of just getting to know the patient. I would say that, the intervention probably takes up the last 25% of the first appointment, but really this is going to be the bulk of the intervention. Monitoring evaluation will be kind of the bulk of subsequent follow-up appointments that you have. So there are a lot of, different things that you can do with interventions. You want to start small and build off of there as not to, overwhelm the patient at one time. But generally some things that you can touch on are education, dietary adjustments, giving guidance on physical activity, guidance on supplements, and medication management. So the primary dietary intervention for MASLD is going to be a hypocaloric diet to, induce a calorie deficit, help the patient rid excess fat that is stored in the liver. The goal amount can vary person to person, and it's impossible for us to, give a patient a magic number to achieve that is going to help resolve their issues. But generally, the literature shows at least a 5% body weight reduction if a person is in early stages, but it could be, more than 10%, especially if a person is in advanced stages. And I threw in here pancreas fat too, because oftentimes patients with MASLD, they'll have fat not only stored, in their liver in excess, but in their pancreas as excess as well. And the literature does show that irrespective of BMI, kind of this target can be helpful. Now, the image I have here is taken from the Counterpoint study, which was kind of the landmark study to inform the twin cycle hypothesis. But basically, they had patients with type 2 diabetes and MASLD go on a very low calorie diet, 800 calories a day for about 8 weeks. With very low calorie diets, we don't exceed 12 weeks with them due to, concern for malnourishment, nutrient insufficiencies, but we've had a lot of subsequent studies since this showing that, decreasing body weight can also decrease intrahepatic fat content. So in this study, during the first 7 days of the 800 calories per day, the fat content was decreased by 30%. So quite a lot. Very low calorie diet is it's not something that I do with my patients. I don't find it necessary. And I would certainly coordinate care with a physician if I were to do that. But, when I approach medical nutrition therapy, I really take a behavioral approach to it. And it doesn't necessarily teach patients how to change their behaviors. It's also difficult to comply with. We also need to consider that, weight loss is not always appropriate for patients. As I said earlier, especially if they have history of disordered eating disorders. If they are in a smaller body, they don't have much weight that they could safely lose. And it's also not acceptable to every patient. I find that, over the past 5 years of, providing counseling, I feel like recently I'm having more patients that don't necessarily want to put concerted efforts towards weight loss. They don't feel like that's the right choice for them. So we need to be able to, look past just weight loss as an intervention and give patients other tools.
Hey, Megan, can I pop in and ask?
Yeah.
Are you familiar with how much weight did they lose in those first 7 days to get that drastic of a 30% reduction?
Yeah, off the top of my head, the number 15 kilograms stands out to me. So that would be, like 35 pounds or so? But I could be, or don't quote me on that, but that's definitely something we can look at later.
I appreciate the citation. I was not familiar with that study.
So yeah, definitely one to look at.
Those pictures.
Yeah, absolutely. So when we think about, modifying the energy balance, we want to ask the question, how does the patient's current energy intake compare to their predicted or measured needs? Of course, we have a lot of different predictive equations that we use. My go-to is usually Mifflin St. Jeor, but at my office, I have the machine to the left that you see here. This is a machine I use to do indirect calorimetry to more precisely measure their calorie needs. Great tool. I love it. And if the patient feels that doing a calorie deficit is an acceptable intervention to them, then we have to come up, what strategies are going to help them best achieve that. For some patients are really interested in tracking calories, tracking macros, being very precise with that. Other patients, that's very stressful. It's very time consuming. It might not be realistic. So we really need to get comfortable with putting as many tools into our patient's toolbox as possible. And part of that is with education. This is a graphic that I show my patients just to kind of show them, kind of what goes into your total daily energy expenditure. I feel like a lot of people overestimate how many calories they can burn from exercise. And so really my focus is, let's burn some with exercise, but also looking at how do we increase NEAT energy, particularly for sedentary, desk workers such as myself. I'm at my desk all day. How can we get some more movement in throughout the day? And influencing metabolic rate too, especially with building muscle, which I would say, most patients I see with muscle definitely could do with some more muscle, which we'll touch on later. But in addition to, the traditional calorie counting, macro tracking to induce a calorie deficit that way, there are lots of non-tracking ways that patients can implement to bring them more towards a place of energy balance or even deficit. So, first place is definitely helping them to gain attunement with their hunger and fullness cues. I feel like, especially if a patient has a long history of yo-yo dieting, fad dieting, if they have a lot of distractions throughout the day, their mental capacities are directed towards other things, it can be really hard to listen to hunger fullness cues. So we work on that. We work on mindfulness of portion sizes, so trying to match portion sizes to hunger and fullness cues. One thing I do with patients sometimes, if they want to kind of take like a more gentle approach to tracking or just generally bringing more attention to portion sizes, is estimating portion sizes with palms, with fingers. You can do that and kind of associate them with the different macros that way. Really helping too patients prioritize home cooked foods. We know when we go out to eat, there's often added oils, added sugars that bulk up the energy density in foods. So in addition to home cooked foods generally improving the quality of the food as far as, micronutrients, fiber goes, it will generally be less energy dense as well. We encourage the patients to minimize added sugars, especially in beverages. We try to help them promote satiety and satisfaction in meals. So, minimizing distractions, especially screen times. I would say a lot of patients report to me they consider themselves fast eaters and overeaters, and trying to make eating an exclusive activity really helps with that. Trying to focus on enhancing flavors. One of the things I do is culinary, cooking classes, trying to really help people enjoy what they're eating. A lot of people have the misperception that healthy eating has to be bland and boring. That's definitely not the case. So really trying to, implement different maybe culinary techniques to help them enjoy their food more. And then also ensuring on the plate they have adequate protein, fats, carbs, fiber, really, making sure that their plate is balanced so that they're staying fuller for longer, they're getting the most out of each meal. And then, of course, encouraging regular physical activity. So, if they're working at a desk all day, encouraging movement breaks, having them set timers on their phone sometimes. Some patients like to set a goal for number of minutes walking or a certain steps per day. And then, the more formal exercise of doing different cardio activities or weight-bearing activities. So I've definitely had patients, change their body composition without necessarily tracking macros, without tracking calories, doing a more gentle approach. So when it comes to, looking at how we might manipulate macronutrients within the diet, there really is no one macronutrient that's better to eat more of, to eat less of. Outcomes are pretty similar in the literature when manipulating the percentage of energy from fat versus carbs, for example, in an isocaloric setting. So it really seems like the most important factor is simply just overall energy balance. There are some nuances within the macros that we'll touch on. But whether a person wants to pursue a higher carb, a higher fat diet, it's really just dependent on their personal preferences and the more nuances that fit within that. There is some very limited evidence for a low glycemic index or low diet for MASLD, but consider their glycemic profile as well. Low glycemic load diets can help improve glycemic profile, and a lot of your patients with MASLD are going to have prediabetes, type 2 diabetes. So I do often find myself encouraging a low glycemic load diet, but ultimately we're trying to personalize to their preferences and ultimately just what will help to promote long-term adherence. So, within dietary fats, evidence is pretty clear that higher intake of saturated fats relative to unsaturated fats, even in an isocaloric content promotes fat accumulation in the liver and insulin resistance. So we really try to help patients make swaps. I would say the three biggest sources of dietary fats that we're making swaps in are their cooking fats, their protein sources, and their sweets. So, cooking fats, if a patient is primarily cooking with butter, with coconut oil, I've seen some plant-based, butter alternatives now that are coconut oil-based, palm oil-based. We want to try to be encouraging to swap those out for things like olive oil, avocado oil, canola oil. And usually with that, there's also additional education on, a lot of people perceive coconut oil to be a better choice because it's plant-based. Not necessarily true because it is still higher in saturated fats. It does still tend to drive up lipids. For protein sources, making swaps, especially with fatty fish for like the fatty ruminant meats, so beef, pork, is going to be helpful. Fatty fish is high in polyunsaturated fats, so we'll touch on that on the next slide. But I will say I do get a lot of confusion from people about dairy products from non-butter dairy, so things like your yogurt, your cheeses, and milks. Those, for me, even though they are higher in saturated fats, they are lower on my priority list for people to avoid. One, because the saturated fats don't tend to affect people's lipids as much because it comes packaged along with casein and whey proteins and calcium that inhibit absorption. And then two, you have to weigh the risk of reduced calcium intake as those sources are huge sources of calcium in the diet. And then the sweets, things like pastries, sweets, especially if they're made with palm oil. We're seeing a lot more sweets made with coconut oil. So making some swaps there as well. But, touching on the fish a little more, your fatty fishes, high in the omega-3 fatty acids, EPA, DHA, particularly seem to be helpful for MASLD. We have in vitro studies showing that they regulate gene transcription factors that stimulate fatty acid oxidation, and they downregulate pro-inflammatory genes. So the degree to which dietary fish intake affects MASLD has not been as widely studied as supplementation except in the context just of a wider Mediterranean diet. But, from that, very hard to tease out effect of just fish. So, at the very least, it is, providing that EPA and DHA, but I do like it as a replacement because it is, kind of crowding out that higher saturated fat that is found in some other meats. So we educate the patient on sources and help them figure out how to enjoy it. Fish is not everyone's cup of tea, and this is also kind of where culinary, nutrition focus can come into play. I would say that common complaints are people not liking their house smelling like fish, fish having a really fishy taste, and you can definitely apply different cooking techniques to kind of attenuate both of those concerns. But if still someone is still not really into eating fish, that's okay too. We'll talk about supplementation in a little bit. And then within the, macronutrient of carbohydrates, it's generally going to be helpful for most people to encourage minimizing added sugars from the standpoint of trying to achieve neutral or negative energy balance, and also to attenuate any issues with glycemic control. However, we do need to be cautious that we're not telling people that sugar is the cause of metabolic dysfunction. There is clear consensus between studies that it's an issue of overfeeding with sugars that leads to increased levels of liver fat, not just that sugar itself is the cause. And the way that I, kind of communicate this or illustrate this to patients is that if you look at Olympic athletes and they're eating several hundred grams of carbs a day, often in the form of sugars, simple sugars, yet they don't have metabolic derangement. Why? Because they're using that energy. And I find that, making this distinction helps patients, not to feel like sugary foods are necessarily off limits. They just need to be matched with their energy expenditure. And, it's true that when we make foods completely off limits, it's more likely to encourage like a restrict binge cycle. So we're really trying to help the patient learn how to just more mindfully integrate the food. So we want to do education on sources of sugar. A lot of people consider, maple syrup and honey, these natural sugars, not to be sugar, but they are. So really trying to do education on sources, maybe helping patients explore alternatives, non-nutritive alternatives. So stevia, monk fruit. Even I've had a lot of patients, so they switch from a regular Coke to a Diet Coke, and if they're drinking it on a daily basis, we still see great improvements in that. And some of that might be a conversation too. A lot of people have concerns about safety of non-nutritive sweeteners, so that will often come up. So make yourself familiar with that. We can also, explore using fruit to sweeten foods that also provide, fiber and micronutrients. But it's also important too, if someone is used to consuming very sweet foods all the time. So, I'm thinking of a patient who maybe starts their day with a really sugary coffee. They're having like sodas or juices throughout the day, lots of sweets, desserts. It does take time for tastes to adjust, usually, a few weeks, a month, a couple months, but it is, patients will adjust to that lack of sweetness in their diet. Not as far as alcohol goes, we are very clear with patients that alcohol is toxic regarding many health outcomes besides MASL. There's no level of safe consumption. There does seem to be, substantial variability in individual susceptibility to alcohol-induced liver injury, and we don't have clarity on like a specific dose required to impact, MASLed disease course at an individual patient level. So I tell patients the less you can drink alcohol is the better. Sometimes it does also help too to educate them on the energy contribution, right? So it's almost similar to the amount of calories contributed per gram is similar to fat. So less looks differently for everyone, and just like with anything with medical nutrition therapy, we really need to meet patients where they're at, not where we feel they should be. And, a lot of people use alcohol as a social tool, as an emotional tool. So I find a lot of the times we're working on replacement strategies. It could look like alternating drinks of alcohol with glasses of water, maybe doing mocktails. Your professor has a great mocktail series on Instagram, so you can get some good recipes from her. But there are a lot of different strategies you can help patients explore. But of course, if you do suspect substance use where it's very problematic, always refer out to, a therapist or other appropriate provider to help them deal with that. But just know that complete abstinence may not necessarily be the goal for everyone. Okay, so those are the primary dietary changes we're using. When it comes to supplements, every patient wants to know, what supplement can they buy, because it can feel so easy to want to have a pill that solves everything. But my mantra is less is more when it comes to supplements. The last thing we want to do is encourage further liver injury, wasted money, and most supplements on the market are just not helpful. They're a waste of money. There's issues with, contamination. So when it comes to mast cell, patients, I would say the ones that they're most interested in or they see the most online would be curcumin, silymarin, CoQ10, probiotics. In my opinion, there's really inadequate either safety or efficacy research on those. Concerning vitamin E, there is adequate efficacy research at a dose of around 700 milligrams, but I personally have a high concern for safety, especially as it comes for increasing risk of hemorrhagic stroke, prostate cancer. So it's just not something that I recommend, especially, when we're working on everything else. I just don't think it's really necessary to take that risk. But if a patient asks about it, you help them weigh the pros and cons so they can make that decision for themselves. The strongest and safest evidence regarding supplementation we have is with EPA and DHA. If someone is vegan, maybe they don't want to do a fish oil source, they can do an algae-based source of preformed DHA. But of course, you always want to coordinate care with physician. With these, it is efficacious at higher doses, usually of, at least 2 grams, but median dose in literature is about 4 grams per day. So I always run it by the physician, especially if they're on maybe medications that might pose contraindications but if a person is also presenting with hypertriglyceridemia where their levels are above 500, they're usually going to be getting a prescription grade 2. So as I said before in the assessment piece, always triple check what supplements and medications people are on. Oftentimes they'll say they don't have a medication that they're on, and then I'll hear about it maybe like halfway through or in the second session. I don't know why. Okay, so even though we are not personal trainers, we are dietitians, we still want to give some guidance on exercise. We want to promote I promote attention to the quality of a patient's muscles, and I kind of I try to position exercise not as some, tedious, boring thing to do, but really an opportunity to build a very robust endocrine organ and encourage, functional ability throughout the lifespan. Patients, I find, tend to be able to put more value in exercise when they understand why their muscles are so important. So we do education on especially sarcopenia. I feel like I am seeing mast cell a lot more in younger people, even in early and mid 20s, but, definitely patients 30 plus, letting them know about sarcopenia. I feel like the same is true, as far as like what I said, patients tend to put more value in exercise when they understand why their muscles are important. The same is true for, I would say, everything in medical nutrition therapy too. Patients really like to understand what's going on in their body, and I find it really helps with compliance as well. They're able to just put more context to what they're doing and why we're asking them to do the things that we ask them. But anyways, so along with just engaging in regular exercise, especially like your strength exercise, your weight-bearing exercise. From a dietary perspective, we want to be encouraging adequate protein intake so that they are able to optimize their muscle synthesis. So helping them find high-quality sources, helping them identify gaps in their dietary pattern. My general recommendation, not pending any concerns that would limit protein intake, would be 1.2 to 1.6 grams of protein per kilogram of body weight per day. Of course, if a patient is at a higher body weight, that might just have to be adjusted. And then I'm also comparing, my calculation to AMDR, the AMDR as well. And, as far as what a dietitian can do, we can also help them to create like a realistic routine with exercise. Although I commonly do refer out to personal trainers for strength training, since I personally, that's not my area of expertise. And at the most affordable end, there are lots of YouTube videos, free videos online. Maybe in the middle, there's a lot of chain gyms like Planet Fitness that might have group classes, one-on-ones, YMCAs, community rec centers, things like that. Or if a patient can't afford a private trainer, even just for a few months to learn basics, learn proper safe form, that is a super helpful investment. So besides strength training, aerobic training, really independent of weight loss, can also improve mast and improve insulin sensitivity. And it's helpful to do education about this because a lot of people they really just tie the value of exercise to weight loss. So if we can, help them expand their value beyond that, that can really help with them maintaining the behavior long term. So again, we're trying to meet patients where they're at. So for some people, they might just be starting out with a daily 10-minute walk if they're completely sedentary at baseline. Other people might be hopping on a bike, might be going for a jog. It just, looks a little differently for everyone. But, generally for patients with poor cardiorespiratory fitness or who can't tolerate maybe function abilities, can't participate in aerobic exercise, strength exercise may actually, be more feasible. Some moves can be done from a seated position, and still independent of weight loss, can aid in improving mast. But generally, a lot of patients who are sedentary at baseline, they're very deconditioned. So encouraging them also to do particularly zone 2 exercises can help to condition them relatively quickly. And then I also wanted to throw in here just a note on medication management. So particularly about the weight loss medications, as a lot more patients are on them. They're on, medications like Ozempic, like Zepbound. So it's really important that you guys get comfortable with understanding your role in helping patients do medication management. So a lot of times, not all the time, but a lot of times patients will have side effects like nausea, like constipation, anorexia, changes in glycemic control. That can be addressed with nutrition support. We also definitely, anytime, regardless of medication, if someone is in a phase of weight loss, we want to be supporting skeletal muscle so that they're, not losing that at the same time. And then also helping the patient, determine their game plan if they plan to come off the medication, especially related to changes in hunger and fullness cues. Because I will say, my experience has been a lot of patients I work with on these medications, they've unfortunately been put very casually on them. So we need to help them think about kind of the long-term game plan with that. All right, and then here we're wrapping it up. I have some recommended resources for you guys. These are all hyperlinked that you can click on. So we have a weight bias test and a paper on weight inclusive versus normative healthcare. I have more information on twin cycle hypothesis, personal fat threshold, and then some resources on counseling skills as well. If you guys do decide, you think you might go into outpatient or private practice where it's more in-depth counseling. I know for me in my dietetics training, I didn't have very specific counseling skills training. That was something I did in my grad experience. So I have some resources for you guys here too. And we can open it up for questions now.
Awesome. Thank you, Megan. Does anyone have questions for her?
Questions from the guidelines.
Okay.
I think one of them, I can't find that one exactly, but I think it said that people who are diagnosed, that you encourage screening for first degree relatives. And that I did see up to 3 cups of coffee a day can reduce liver damage. Do you discuss that with the patients and their family?
Yeah.
Did you hear that question about the cups of coffee?
Right. So the coffee, I don't use that as an intervention. It's not really like high priority for me. And I generally find that if people are not already drinking coffee, it's usually because they don't like it or they are sensitive to caffeine. Like maybe they, are slow metabolizers of caffeine. So I don't typically recommend coffee intake. As far as the screening though, yes. So screening for family members is recommended. Especially, and I think that makes a lot of sense, right? Especially as like there seems to be a genetic component to insulin resistance and diabetes. I think that makes a lot of sense for family members to also get screened.
Anyone else?
I have a similar question to Supro. It's also about screening, but mine is the guidelines said that patients who have liver disease could also have an association with having celiac disease. So I was wondering if this is something that you've seen in practice, and if so, is it difficult for patients to like follow a low saturated kind of diet lifestyle and celiac disease lifestyle?
I would say no. So yes, I would say not frequently, but I have had patients with celiac that have also had MASL, but I don't find it's difficult for them to adhere to kind of like the dietary interventions. I would say most of my patients prefer to do like lower carb, higher unsaturated fat, moderate protein diet anyways. And certainly reducing sources of gluten kind of align with that. So I would not say it's very difficult.
Thank you.
Thank you.
Sure.
Yeah.
How long, so since weight loss is recommended and like low calorie diets, how long how long does a patient have to be on a low calorie diet in order to see like improvements in liver fat?
Yeah, great question. So usually I'm coordinating with the patient's physician to get, whether it's like a new ultrasound or lab work. I mean, definitely for the lab work, I would expect to see, if a person is sustaining weight loss, they're on a pretty good trajectory. We're typically retesting things like their A1C, their lipid panel, maybe after like 3 to 4 months to see where the needle is kind of budging on that. And the physician may elect to repeat ultrasound at that time, but it also depends, I would say, on their insurance coverage too. A lot of plans won't cover like a repeat ultrasound necessarily within like the calendar year. So unfortunately, I would say insurance also plays a role in kind of like our plan for a reassessment. But I would say, there's no like magic, number of months someone has to be on a pursuing weight loss or a, magic number to see on the scale. It's really on an individual basis. But I'm really looking at the needle to move on those lab values.
Yeah, thanks. So it's like because of the scans, you're using these surrogate markers, sounds like, to see if you're making progress.
Exactly.
Awesome. Anyone else?
Mine's like sort of similar to Julie's, and I wouldn't cover monitoring and evaluation in this presentation, but in terms of doing so, will you just stop seeing a patient once their markers have normalized, and then, or do you like plan like maybe a year later to see them again just to check up on how things are doing, or how do you go about that?
Yeah, great question. So I do prefer to see patients even afterwards because I mean it in the literature too. It's interesting, right? Like I'm sure you guys have seen that statistic thrown around, like 98% of diets don't work or whatever. it's interesting in the literature because, weight loss can be sustained for years with interdisciplinary support, right? Having someone like a dietitian on the care team that a patient can somewhat routinely check in with, especially as life circumstances change, health status changes, that can bring about nutrition related changes and sometimes barriers to sustaining weight loss. So I think also what plays a role into how long I see a patient is definitely like the financial affordability aspect of it. For me personally, since I don't take insurance, that can sometimes be a barrier as well. So we're also cognizant of that. And so spacing appointments out might look a little differently for patients. But I tell patients generally plan to see me for 3 to 6 months at the minimum.
Thank you.
Thank you.
Thanks.
Kind of on that note, I was just wondering if like from the counterpoint study that you showed, did they do follow-ups and like what did their liver fat look like at longer time?
Yeah, off the top of my head, I cannot remember how. Actually, I might have the paper linked here. Let's see if this is. Okay. All right, that doesn't seem to want to work. But off the top of my head, I cannot remember the duration of the study. I know at least the intervention of the low-calorie diet was 8 weeks, but I can't off the top of my head remember if they followed up after that to kind of monitor how long they sustained that for.
Yeah, thank you. I'll look into that for sure. I was not familiar with that study, and I think it's maybe more like a proof of concept about if you lose that weight, just how that liver fat almost like disappeared in that image.
Yeah,
wild.
it is wild. Yeah, I do believe that this paper links to that.
Anyone else? I can repeat what you got.
Would you ever have any patients where like mantle, but it's like progressed so far that it's gone to like cirrhosis, like I think like liver transplant and maybe like bariatric surgery, which is like 2 very major surgeries.
Yeah.
And then like how is she approached with like lifestyle approaches, considering the fact that they just have or will have
Upcoming surgery. But she was asking about, have you seen anyone where MASLD has progressed into like MASH or cirrhosis? And have you maybe preparing for bariatric surgery or something? Have you seen patients that far along? And how do you approach your nutrition intervention?
Yeah, I have not seen any patients where it has progressed to NASH or cirrhosis. Yeah, I haven't ran into that. Usually I'm seeing patients who are not that far along.
I have a question about, like you had mentioned, you're seeing some in their 20s.
Yes.
That related to overweight or obesity, or are you seeing a lot of lean MASLD?
I would say a combination of both. I mean, even I have a best friend and he's my age, we're 28, and he got diagnosed a few years ago. And I do think it is, related to rise in obesity, but also like rise in just sedentary lifestyle, especially related to just the types of jobs we work. But then in, lean people, I actually see it more frequently in the lean PCOS phenotype, where, you have that lean phenotype that has just naturally lower insulin sensitivity.
Yeah, because we know that PCOS has that insulin resistance piece. And so I would assume then your nutrition intervention, we're not looking at the weight, you're doing more of the maybe physical activity piece, or what do you do to help support that insulin sensitivity?
Exactly. So it'd be that physical activity piece, really focusing on the quality and mass of the muscle, and then a lower glycemic diet as well, usually for like a lean PCOS. Usually, trying to target like 45% or so, of course, according to patient preferences as well, but generally around 45-50% of calories coming from carbohydrates.
You're getting a little lower carb.
Mm-hmm.
Becca,
I
you had a
have
question?
a follow-up question, what Eunice was saying, like she was saying that if she hasn't seen it progress to fibrosis, has she ever seen bariatric surgery patients, or like how often?
Yeah. Do you see any bariatric surgery patients?
I don't.
No.
Follow-up question.
Yeah.
She's talking about, patients that are resistant to weight loss. I'm curious, like, what strategies that she has, like, to recommend that, for like long-term health outcomes in patients that are resistant to weight loss, because I think that can definitely be applicable for many other
Yeah.
conditions.
Yeah. How do you approach patients that aren't open to the weight loss piece for management of not only MASL, but maybe other health conditions?
Yeah, so really putting more of a focus just on the dietary quality. So, whether that is like the macronutrient composition on the plate, portion sizes, but not like from a tracking perspective. Maybe we look at like volumetric or like hand portion size approximates. And then, just focus on physical activity as well. I really think for a lot of people, a big focus is on physical activity. I mean, like I feel like it's so frequent. I see patients that are developing MASLD and prediabetes, and they tell me, Megan, like I haven't changed my way of eating, so I don't know how to eat any different. And it's really like maybe they've made a transition from college student, you're walking around campus everywhere, to then you're at a sedentary desk job, or maybe a new mom or something that maybe was on her feet working before, and now she's just at home with the baby sitting a little bit more. So I think that for people who want kind of like the non-diet essentially approach, it's more looking at dietary quality and then physical activity.
Thank you.
Like present, or wait, sorry, let me give some context. I know you said like with some patients they are able to count their calories and some prefer more like the gentle nutrition. How do you like present that?
So how would you present
I
the
guess,
approaches?
yeah, like does she, I guess like, do you say like for some people like this works, others like prefer not to
yeah.
focus on like the calories?
Yeah. Are you offering like here are options about approaching weight loss? We could count calories. We could talk about portion control. How do you present those options for them?
Yeah,
Because I feel like sometimes too, patients kind of come with the misconception that you are going to put them on some calorie counting diet.
That is often the misperception. So the way I open that conversation is actually just with the education about what MASLD is, especially the idea that you're basically surpassing your ability to store energy subcutaneously, and it's moving to visceral fat storage. And when I do kind of like that education, I open the question to them and I ask them, what do they think about this? And often that leads into the conversation of how the patient thinks that they might go about kind of correcting it. And then it's a conversation of, okay, this is generally what we recommend. There's a whole spectrum of ways we can do it. What do you think about it? And kind of like, what is your history, with dieting, your relationship with food? A lot of the session is like open-ended questions because, as the dietitian, your care should be patient-centered, and they also need to have buy-in into what they're doing. So we try to ask a lot of open-ended questions and help the patient, direct their own care and make their own decisions as well with the information that you're providing them. So yeah, it is tricky though, because you want to be sensitive. We're not trying to push like any one way onto patients, and I think it's really awesome, like the attention recently with weight inclusive healthcare. But yeah, it's definitely a tricky kind of like conversation to navigate. But I try to just ask a lot of open-ended questions and continuously assess what the patient thinks about the information I'm communicating to them.
I love that your approach is to educate about the condition and then leave it up to them. You're giving that kind of autonomy to think about what they'd like to do next with that. I think we can't make the assumption that they understand their disease. And as you were explaining, and as they had learned the pathophys video, it's complicated. MASLD is complicated.
I have another question.
Yeah.
I've experienced this a little bit and just wanted to, this kind of related to my weight loss question, but for patients that you see that are frequent every 3 to 6 months or whatever, that weight loss isn't happening, what do you do in those situations? Because I've experienced, like, sometimes it's hard for me to determine whether it's a lack of like reporting bias, basically, or yeah, whether it's reporting bias or the intervention is just truly not working for them and there's maybe something else going on. And so my question is, what strategies do you recommend when that weight loss isn't happening?
Yeah, I mean, I think that first just kind of depends on the interventions you're doing in the first place, whether that person is doing kind of like the more meticulous food tracking or if they're taking like a more gentle approach to it. That would probably influence my answer a little bit. But, in the case that maybe they are tracking, especially if they're like new to it, right? There's a difference between the information that you glean from, for example, weighing a food versus volumetrically measuring it versus eyeballing portion sizes. Are they tracking, their beverages or, snacks throughout the day, added cooking oil? So if they are doing the tracking, trying to make sure that they are doing it properly. It seems like they're doing it accurately, they're doing it consistently. Usually I wait like 3 weeks before changing. For example, if we were going to change like their calorie target, I'd wait like a few weeks to see, is the scale moving in a different direction? But then also, that's where those other anthropometric measurements can sometimes help too, especially like the waist circumference. Some patients feel like they don't really see, the number on the scale move so much, but then maybe their pants fit a little looser. Their clothes might fit a little bit differently. So yeah, does that make sense?
Yeah, that was a great answer. Thank you so much.
Yeah. So you look at some other measurements that might help the patient and then checking that they're tracking correctly.
Mm-hmm.
Yeah. I had one question about the cardio coach that you're using.
Yes.
I had not seen that before. What is the cost to patients? And do you find that that's a helpful tool that patients like having that information?
Yeah. So, cost to patient. So I always do it as like the test plus counseling session. So that would be $220. And then usefulness, it is only useful if a patient, well, I will say in general, the testing is useful in 2 cases. One, if a patient feels like, man, I've been trying to like lose weight, like I can't figure out, I'm tracking my calories, it's just not making sense why I'm not seeing the scale move. It can be useful to diagnose that, especially if it's a patient who's had like a long period of chronic dieting, a lot of weight fluctuations. Sometimes their resting metabolic rate is, it's maybe adapted lower than what we would expect through predictive equations. But I would say too, it's only helpful if a patient is actually going to do something with that information. So when, people are calling about it, I'm also, I'm assessing, okay, what do you want to do with this information? Because I don't want to run the test if they're not actually going to use it like for calorie or macro tracking, for example. But then also too, I'm wanting to assess their history of, disordered eating, and really making sure it's a safe test to run for them as well. I always have that conversation with patients too, if this information is going to be, more helpful or harmful to them.
Yeah, that's really insightful. Like, so there's going to be new technology coming in, and we need to still navigate with our patients about what it's really we're going to do with that information. So I thought that was cool. I think it's just a helpful tool when people are like, my metabolism's slow.
Yeah.
Know where you're at. Awesome. Well, Megan, I just want to thank you so much for your time today, providing your insights into how you run your practice and approach your patients. It was really insightful.
Awesome. Thank you so much for having me. I will email this to you so all of your students have the slides. And then if any of them have questions, feel free to pass them along to me or they can contact me directly as well.
Yeah, sounds great. Thank you.
Awesome. Thank you guys.